afternoon, everybody. Welcome to this webinar today. It is on managing endometriosis in the workplace, and Lara's going to be talking to us about endometriosis and adenomyosis as well. We've also got Mark Morris, who's going to come in after Lara has spoken, and he'll be talking to us about health and safety and work around endometriosis as well. Can I just remind you about the code of conduct that will have been up when you were in the waiting room? This is a safe space, so please do feel free to ask questions. But if you're doing that, can you put them in the Q&A box, please, so that I can monitor them and I will ask Lara them on your behalf. So welcome, Lara. Lovely to see you again. And I'm going to pass straight over to you, if that's okay.
Yeah, that's great. Thank you, Claire. Well, as Claire said, I'm Lara Morris. I'm a member of NASUWT, have been for many years since I was a student, X number of years ago. I have had endometriosis for 43 years, and I've had adenomyosis for 36 years, and I'll explain what those two are as we go along. As you can see from the slide, that there's, I hope everybody can see the
Lara,
slide.
we can't see your slides, Lara.
Can't see them, okay. Let's check.
I'm happy to share your screen, share my screen if you're struggling.
Okay.
Oh,
thank you.
No. We can see a blue screen.
Yeah, that's what I had before. No, it's fine.
And your slides that have come on now.
They have. Great.
Yeah.
That's brilliant. Yeah, so as you can see, I'm a supply teacher because of my disability, and involved in the Disabled Advisory Committee for the NASUWT. Outside of that, I was helped enormously by a group called Fair Treatment Women of Wales, and I'm an advocate and I'm an endo and menopause champion for them. And also involved in the All Wales Cross-Party Committee for, all women, Cross-Party Committee for Wales with the Senedd in Wales. So that's me, really. Disclaimer is that I am not medically trained, although 43 years of this condition, I've listened to an awful lot of talks by my consultants and my chronic pain manager on this, and have spoken to many women and advised many women regarding this condition. It is an invisible condition, something that very often people can't see. You can see somebody looking perhaps a bit tired, but that's about it. So I've had this, like I said, for those number of years, but I've been involved, I would say, with FTW for 7 years out of that. So yeah, so we move on to the next slide. So for those who can't pronounce endometriosis, took me a while in the beginning because I didn't know what it was. And I virtually diagnosed myself. So we split it up. Endo, meaning outside, metriosis, okay? Some doctors that I've seen, locums and some GPs, haven't been able to pronounce it themselves. They get next to no sort of training on this. They get about, I think it's an hour, and all they're told in that hour is that may cause pain, and that's it. That's from the words of my consultant. Those aren't my words. So there are specialist consultants out there. So what is it? What are the symptoms? As reps, I'm sure you'd want to know, and what people have said to you about the condition and the impact on their lives and in the workplace. So that's what I'm going to talk about a bit more. It can't be diagnosed by a blood test. It has to be diagnosed mainly by laparoscopy, which is keyhole surgery. And the symptoms may vary with endo. You can have a small amount of endo and be in agony. and you can have a large amount of endo and not have any pain at all. So I will go into that in more detail, but it does grade. It's a bit like cancer in that it spreads to many organs, but it is graded from 1 to 4, with 4 being the worst. Okay, so next slide is what it actually is. Some newspaper articles and magazines say it is the lining of the womb. It's not. It's similar to the cells inside the womb, but it's not exactly the same. And it grows outside and bleeds internally the time of the month. It is as common as asthma and diabetes because 1 in 10 ladies and those assigned female at birth have it. It is, as I said, can be diagnosed from puberty, and I teach girls who are in agony. And as my consultant and many consultants who specialise in this condition say, you shouldn't be in agony time of the month. That's not normal. So things need to be red flags. You shouldn't be in pain. You shouldn't be in pain for 10 fortnight of pain, which was in my case. For women and girls with grade 4 endo, the impact, like I said, as you can see on the screen, I don't want to read every single slide, but it is devastating because it does take over your life. There's loss of work, hence me being a supply teacher, and the infertility that can come with it. So basically, as I said, the gold standard, the only real test, you can't be diagnosed with an ultrasound. I had many of those, but they don't work because they don't show anything up at all, and there's no blood test. So the scarring and adhesions, which represent themselves as endometriosis, can develop over time, and they bleed internally as well during time of the month. And the actual symptoms of endo, as they progress to being worse and worse, start maybe slightly before and during your period, and then it can be before, during, and after. So you find yourself in agony for the whole month, basically, in varying degrees of pain. The chronic pelvic pain is horrendous, and the radiating pain, arms, legs. So it's not just an abdominal condition. It can take over your whole body. Sciatic nerve pain I have, lower back, arms, and so on. The bowel impact and the bladder impact is quite immense. A friend of mine in North Wales has 2 bags, one ileostomy for her bladder and one bowel bag, because one stoma, because her endometriosis infiltrated both those. And so she's 30 years of age living with that. So it can take over your whole body. Endometriosis has been found in the lungs. One lady actually had it in her nose, believe it or not. So it can actually go into the bloodstream in that way. So thoracic endometriosis is the thing as well. So I'm not going to go through every single detail. The chronic fatigue is debilitating because not only are you in constant pain, but you're also on quite high painkillers, which I'll go through in a minute. The subfertile means that you are actually, you find it difficult to get pregnant. It's not impossible for women to become pregnant, but I was told that I was subfertile. So at that point, you know, things can be made difficult for women and upsetting. My right ovary was in fact stuck to my womb, so that had to be taken out. So you can actually survive and carry on with the one remaining ovary, but obviously that can be infected. And the more surgery you have, obviously, the more adhesions you have. So I've had 10 surgeries altogether, but in the beginning, as you can see on this particular slide, and there is no cure, But the ablation surgery that I had in the beginning does what it says on the tin, it ablates, so it burns out the endo. So it's like the tip of the iceberg is removed. Whereas endometriosis specialists do excision surgery where they cut deep into the endo to get the root out. And this can only be had at the British Gynecology Centres of Excellence, the BGCE centres. Now in Wales, we only have 2. In England, there are many more. In Scotland, Northern Ireland, this may vary. So they are limited, but they are across the country. So it is advisable, really, if you can get to see an endometriosis specialist, these are the key places where consultants and the whole team, the chronic pain nurse, would be able to help you. So in the beginning, women are prescribed anti-inflammatories. I was teaching full time on ibuprofen, paracetamol. But it didn't really do much, to be honest. Younger women particularly, are given the pill, but this only masks the symptoms. So when they come off the pill or variations of, then the endo flares up, and in some cases worse than ever. IUS coil can be used. In my case, that made things 10 times worse. Some people find it fine. Some women's bodies actually repel this. There are TENS machines that people can use, and I'd advise people to use the larger pads for that, which is what's called the maternal pads instead of the normal pain pads. That's what was advised to me. Cold, believe it or not directly on the abdomen or lower back, wrapped in a towel or something can help. Hot water bottle, and many women were burnt by hot water bottles because they got them strapped to them. That's not advisable. Lidocaine patches were superb, from my opinion, because they are just anesthetic patches. You can put on 12 hours, and they ease the pain a bit during the day, particularly a teaching day. Pain clinics people go to, they quite helpful for me in that I was given the pain modifier amitriptyline, which and nortriptyline, which is usually used for people suffering with depression, but it has been found that these were great. The amitriptyline had a what I would call a sort of hangover effect in the morning when I was getting ready for work, so I went off that. And there is another one called nortriptyline, and I'm going to bore you with all the medical details, but they do work better. So women as young as 20, even younger, in order to have some pain relief from endometriosis, some consultants advise a chemical menopause, which shuts down the periods completely. So women have Zoladex, Prostrop, Lupron injections, and these stop the periods and supposedly stop the pain. In my case, and many women that I know, the side effects of these medications are a lot worse than the actual medication themselves, because 1, they don't always stop the pain, and 2, the brain fog and the flushes and the migraines and the depression as a result, in my case, suicidal and Prostrap, they are quite horrendous drugs. So they're used in extreme cases, but bearing in mind that women might have HRT with that, or they can be given on their own. In the past, they have been given on their own. But basically, the physio can help. What I mean by physio is sports physio, so that the person doing it, not necessarily on the abdomen, but on the back, to knock off nerves. And so, because it's so tense with endometriosis and adenomyosis, they can relieve some of the pain. And this was a great help for me, to be honest. I paid, I don't know how much money on alternative therapies, things like acupuncture, Chinese herbs, you name it, I tried it just to get myself into work. But the best thing was the sports physio. Pelvic physio, in an ideal circumstance, and maybe in England where there's more money than in Wales, these are people who work alongside the team and provide on the NHS and provide pelvic physio for women who are to relieve their pain from endometriosis and adenomyosis. Okay, this is something that I found really interesting, to be honest. I wasn't really keen on going, but I attended this seminar in Cardiff University, and it was with an artist, a doctor, and well, no, it wasn't an endometriosis, it was a nurse actually. And there was also a young student who had just started a medical training and wanted to know a little bit more about endometriosis. I think the poor girl was bombarded with us, to be honest. But these are some of the diagrams that ladies came up with. So one of the things that stood out with me is that when you have an endometriosis consultation, you have to draw on your body where the endo is. So as you can see in the bottom left, it's up that person's back, it's in the front, up towards her chest, down her legs. But another thing that stood out and was quite refreshing, I suppose, for me, not having been able to have children, is that this person said, I would rather go through labour than suffer endometriosis flares, because they ask you on a grade of 1 to 10 what your pain level is like. And mine went from, I'd say, from a good day, about 5 or 6, up to about 10, 11 out of 10 some days, because it was excruciating. And you couldn't drive either to get to work even. So this sort of, this is by people other than myself then with the condition. And we were there to educate this young student really, because they don't get much training on it. Okay, so moving on. Adenomyosis. So again, this is quite hard and the spelling isn't brilliant to get your head around, but adenomyosis is the way you pronounce it. And whereas endometriosis is outside the womb, adenomyosis adds to the womb and is inside. Again, 1 in 10 women have it. There's no cure if the aim is for pregnancy, and symptoms overlap in both conditions, to be honest. From my point of view, they did. The big one I found was the bloating and the excruciating, what I used to call my barbed wire pain, because it was internal and it was scraping inside me in that area then. The disease, many people call it the endometriosis evil twin sister, and it is. It's pretty horrific. They do like to leave it alone if you're thinking of pregnancy. However, the disease itself infiltrates the lining of the womb then into the muscle layer of the womb. So it embeds itself and that bleeds internally time of the month. So as you can imagine, the pain is pretty horrific. Again, it's debilitating. Again, like I've said, heavy periods, and heavy periods are not normal, spoken by my consultant, not by me, and irregular sometimes, but also the heaviness and the discomfort of the pelvis. Painful bowel movements, yes, that's common. But if people are trying to get pregnant, and you've got members who are trying to get pregnant with endo, you would find that miscarriages would be common and sometimes premature births. Okay, so treatments for endometriosis is slightly different than endo, in that I just draw your attention to the new drug that's come on the market that I haven't had, but other women have had, is Dianogest. And that is supposed to be a chemical menopause again. So it's similar to the others where everything stops. And the other two drugs that I was given to reduce pain and bleeding were tranexamic acid and mefenic acid. Now, these two drugs are supposed to reduce pain, and as I said, reduce the bleeding quite a bit for women. Sometimes they work for some ladies, sometimes they don't. But the main definitive treatment is actually a hysterectomy. And in my case, I've still got pain now, but I've got endometriosis pain. I haven't got adenomyosis because I had a hysterectomy. So that excruciating barbed wire pain is gone for me. Which is a relief in many ways. There are a huge impact, obviously, for teachers working with this condition. And in Wales, the diagnosis takes at least 9 years to be diagnosed. I was 13 years before I had the official diagnosis and paid privately for a laparoscopy. It's a year longer in England. Not really sure about Scotland and Northern Ireland. But many women are not really able to sort of define their condition until they get their diagnosis to their employer or their head teachers or whoever. So once they have it, then, you know, things could be put in place as long as, obviously, they've had it for more than 12 months and reasonable adjustments can be made. Once diagnosed, very often with endo and ad, I'll call it, it can be wide-ranging. So it's the mental health impact on women, on teachers who suffer with this, on top of their daily work, is quite awful, to be honest. And it's debilitating. It takes over your whole body, but you also feel depressed because you can't work to your full potential then. And many employers, like I've said, dismiss it as just all in your head, or, you know, it's just women's problems. And many in the past, many doctors have referred it to as being all in women's heads and have often diagnosed depressants for women suffering from endometriosis, a bit like the menopause, really. So many believe that if they in my case, my head teacher said, if you get pregnant, then it won't be a problem with time off for me in the future. Surgery, they believe is a cure, well, it's not. So missing work, this often leads to, as I've said, job insecurity and bullying, to be honest, from many employers because they don't understand it. And again, the figures are pretty harsh. 8.2 billion in the economy, and the impact on employment is an awful lot. However, if this is nipped in the bud early, and I know of a colleague who, a friend, sorry, who's not a teacher, she works for Admiral, who are an endometriosis friendly employer, would you believe? And they have immediately, when she informed her HR that she was going to be working there, and she informed them she's going to have surgery, and she suffered with this condition, and it was a disability, reasonable adjustments were put in place immediately. They asked her what level of desk she wanted. They asked the timings of the day when she could work from home. This obviously isn't suitable for, you know, teachers working from home, but maybe a slight alteration in timetable would help in some ways. But the figures are quite startling in that 40% of women with endometriosis and adenomyosis fear losing their jobs. 54% of endo sufferers had reduced income. and 87% of endometriosis sufferers has it's impacted their life financially. And overall, 1 in 6 women with endometriosis would give up work. So it's, you know, my employer bullied me for over 6 years with it, but there are people out there who have gone through the same. And some women don't feel confident to talk about it because it is a female condition, or those assigned female at birth. And they don't disclose it at an interview. But once the employer knows, and you have somebody who could make reasonable adjustments, there are many, I think, that could be put in place. I know of some that would have helped me. For instance, somebody taking my register in the morning, somebody while I sort of came to on my medication, maybe starting a bit later, just different type of work pathways, just something simple as being near a toilet, water supply, anything like that would have helped me, I know for a fact, and other teachers trying to cope with this condition. So that's it from me, really. But somebody who's had to live with me for this length of time and been to numerous hospitals is Mark Morris. So he's got all the reasonable adjustments that people need to know about trying to deal with this condition. Thank
That's
you.
brilliant, Lara. Thanks for that. We've just got one question in the Q&A box.
Yeah.
Sean's asked, how common is adenomyosis in respect of endometriosis?
How common?
Yeah.
I would say that you usually find that a lot of ladies with endometriosis have adenomyosis as well. So I don't know the exact figures, but I would say that is pretty high. And my consultant would probably say it's pretty high. The difficulty is working out if a person's got it. So a friend of mine had an MRI recently to see whether she had it. But they don't really know 100% that you've got it until they take away the womb, and then they can see what's inside. So the two overlap quite a bit, to be honest. Some people may have adenomyosis and only a small amount of endo, and not so much of the endometriosis, ovary pain and pelvic pain and heavy bowel and bladder. So it varies, to be honest. Everybody's different, Claire.
Okay. Why does it take doctors so long to diagnose? Is it just because they've not received enough training on it, or what?
No, because the symptoms vary so much. And with the bowel, if people are in agony with their bowel, I paid privately to go to Harley Street, and that doctor told me I didn't have endo, I had IBS.
Right.
So,
Helpful.
yeah. So some of them say, I was told I had varicose veins of the uterus, would you believe? That was early on, actually. I was quite young when I was told that. To take water tablets, and that would help. Many are told they'll grow out of it if you're young. And as I said, IBS is a big one that people are misdiagnosed with. Things like could be colitis, it could be something else, it could be, but they don't really know 100%. And unless you get yourself or ask your GP to get yourself to a specialist endometriosis consultant and centre, virtually all, well, a lot, I'd say, I wouldn't say all gynecologists generalise. So they don't really know a great deal about endometriosis and adenomyosis.
I take it more research is being done, or I hope more research is being done.
There's new research coming out every day, apparently. Speaking to my consultant, and he works with consultants in America, and says that there is new research. I think this is where this Dienergest came from, and works for some people, doesn't work for others. But no, and nobody knows why it happens. I was told by one consultant that it's a Western women's condition, that a lot of women in Asia and Eastern Europe don't get it so often. So maybe it's diet as well, or environment, but basically what it boils down to is if those cells are going to grow outside, they grow outside and that's it,
Yeah.
endo. Obviously with inside the womb, then that may be different. But yeah, and it's very hard as a teacher to, well, to function sometimes when you're in agony and you can't think
Yeah.
straight when you've got a class of kids in front of you.
Yeah.
But yeah,
And we
any,
need to raise awareness, don't we? Like we're raising awareness around menopause and delivering
yeah,
menopause training and making employers, making our head teachers and trusts, etc., aware around
yes.
menopause. We need to be making sure that we're getting the message out around endometriosis and adenomyosis as well.
Well,
So,
it would be nice to have endometriosis-friendly schools
mm,
and adenomyosis-friendly schools, as well as, a colleague of mine having with her employer because they've fallen over backwards for her, which is
yeah,
amazing. I find it like a breath of fresh air because I never had it, that's for sure. But I
mm,
went through all this prior to the 2010 Equality Act.
yeah,
Um, but also there was discrimination at work that I could have
mm,
raised. But a lot of people are worn down and just think, well, I just can't cope and I'm getting out.
yeah.
So yeah, any other questions?
Let me just double check. I think one may have come in. Yeah, just one from Raquel, and then I'll let you swap seats with Mark. Would you advise members to let not only their head teacher know if they have a diagnosis, but also the HR department? Yes, definitely.
Absolutely, absolutely. Yeah. I went for my job interview with the boss that bullied me, and I was in absolute agony. And I sat for the interview, and I didn't tell him initially. And then when I was employed, I told him, and he said, if I knew you had the condition, I would have employed you. But that goes on a lot.
Mm,
However, in reality, once they know, it's like depression, it's like any disability, really. If they know, then reasonable adjustments can be made
mm.
for you.
It
Um,
should be made for you.
yeah,
Yeah,
yeah. So yeah,
yeah. That's brilliant, Lara. Thanks for that. Yeah, been as always really useful, and I'm sure people have I'm not going to say loved hearing the story, but perhaps have had their eyes opened a bit more. So
well,
thanks for that, Lara.
it's just that I wanted to say that we did the one webinar in March that people
Mm,
might have awareness of with my consultant and my chronic pain nurse,
yeah,
who actually attended in their scrubs, and they were brilliant. And the other two
yeah,
ladies who joined us. So for members in general who do want to have a look at that, not just reps, that's a good one to look at, not just because I'm on it, but because other people's opinions across the
yeah.
country are just as important. Thank you.
Lovely, Lara. Thanks a lot. Right, come on, Mark.
Okay, excuse me all, we're just shuffling around here. It was just much easier to have the one computer to do this on in the one house. So
We don't mind you still being called Lara Morris either.
right, if I can just end this one and you can tell me, Claire, when I've shared the other one.
Yeah, no problem. Just so everybody's aware, this is Mark Morris. Mark Morris is a national executive member and he's chair of our National Health and Safety Committee as well. So, yeah, we can see your slides. Yeah, that's absolutely fine, Mark. So I'll pass over to you.
Oh, brilliant. Thank you, Claire. Okay, so welcome. Good afternoon, everybody. So Lara's given you an idea about what the medical condition is, and also sort of said about, and Claire has as well too, about joint reasonable adjustments and things. Well, we bandy these terms around sometimes, and we don't actually say what they are. So I'm going to deal with this from the approach of my experience in dealing with casework, basically, and just to show.
Mark,
Yeah.
Sorry, do you want to change the way you're displaying your slides, because we can see the next slide that's coming up as well?
Okie doke. That's good. I don't know how I've done that. So if I stop my share and then go to share screen and pick up, hopefully, that one. Is that it?
Yeah, that's great, Matt.
Brilliant. Okay. So, yeah, as Claire said, I'm a national executive member as well for South East Wales. I share the district with Sharon, District 31. I'm chair of the National Health and Safety Committee at the moment, and I'm, as well as being a classroom teacher for 30 years, I'm local secretary for Merthyr Tydfil. I'm a school and local authority health and safety rep, and I chair the Wales Organising Committee as well. So, and a fair few years doing this as local secretary. So I think 20 years now as local secretary. So a lot of experience of dealing with casework. And, you know, one of the roles of the national executive member is to assist other local secretaries in dealing with casework. And that's where you get that breadth of knowledge from, helping them and talking through casework with them. Now, I don't know how many of you have done any reps training, but I'm going to talk through this in a technique we use with school reps, which is PIPO, or problem, information, plan and organising. And I've jumped through my slides there, so I'll go to the next one. That was stupid of me. So using those as a way of organising your thinking around dealing with casework. So the problems with endometriosis and these other conditions that are sort of linked. One of the most common ones is the sickness absence record. And you in your schools, your colleges, your whether your local authority or trust or whatever type of school it is, will have different ways of dealing with sickness absence. And there are some out there that are pretty draconian in their application. And a condition like endometriosis, because it's times in nicely with the month, looks like a regular pattern. So employers like to be able to jump on that because they can say, "Ah, but you did this 28 days ago as well," you know. So it's a very easy one for them to pick on and pick out a pattern with. So the sorts of problems, and Laura mentioned a few that she had in her experiences. You could be so the problem could be that your sickness absence record is causing you to be attending welfare meetings, occupational health meetings, being some of the policies. And I just sorted out a meeting for Monday, I think, about somebody who's going to end up with a disciplinary on their record because of their sickness absence record. And of course, we'll have ways of challenging those, which I'll come on to in a minute, maybe. In extreme cases, of course, you have medical capability where the person is no longer able to do their job. So that's different from performance capability, which I've got the next one there. That's where their ability to do the job day in, day out, their performance in that role is being affected by their illness. So, like Laura said, being having brain fog, having the cramps and the pain that goes with the condition. Basically affecting your performance. And it's amazing, again, how many employers in their way of dealing with this will then force an employee into reducing their hours because, of course, earning less and working less is not going to affect your condition one bit. And you can't decide which Monday or Tuesday, Wednesday or Thursday is going to be the day that you're going to be in the most pain. But it seems to be the way up. It's okay, then you can cope with that pain through Monday, Tuesday, Wednesday, and then you've got Thursday, Friday, and the weekend to recover, to come back in and flog yourself to death for the rest of the week there. Another simple one might be that the workplace adaptations are not being addressed in a reasonable adjustment, which I'll come on to in a minute, to address some of the things that Laura mentioned that needed doing, like being able to go to the toilet quicker and easier, to be able to go and change sanitary provisions and stuff like that. Simple adaptations or moving of classrooms or provision of additional toilets or whatever in the school would stop those things being done. So those need to be addressed as well. Lara mentioned this, I think, the bullying from SLT or other staff. I'm sure we've all heard those conversations in the staff room where they go, oh, so-and-so's off again, you know, they're only part-time and they still can't make it in on Monday and Tuesday. So it comes from staff and, of course, from SLT who may couch it under terms of, you know, this is a financial burden we cannot continue with, you know. So deciding on the problem is really often difficult because of the members' views of this situation. They might contact us seeking some advice about a workplace issue, but not be aware of the contractual or the legal rights and the responsibilities, most importantly, of the employer. I suppose the approach, I mean, deciding on what the problem is the same as you would with any other gynecological issue, or even other Equality Act provisions such as disability. So these are some of the most common causes of a member approaching the union for help. So those are the sorts of problems. So the information that you're going to need to try and work out how to deal with this problem. This often comes from a discussion with the member. And basically, it's about finding out what is the effect it's having on the member. And some of these are really a problem too, because as a person dealing with some of this casework, you've got to be able to be comfortable in dealing with those conversations now, and the member's got to be comfortable with having those conversations with you. So it's a real difficulty. I'm quite happy having these discussions, but then, as I say, I've been doing it for 20 years and I'm used to having these discussions. I can imagine that for a member who's a woman having to talk to a male caseworker, that might prove to be difficult. But likewise, it might be difficult for the male caseworker to deal with those conversations anyway. But that's the sort of conversation that you can have in supporting the member about who's a suitable person to be supporting them. Because it might be that the school isn't very comfortable having these conversations with people either, and so it's all being hushed and ignored. So when dealing with any casework, really, I think the important things is to listen to the member, to hear what they've got to say, reflect on what they've got to say, and feed it back to them. So you're showing that you've got an understanding of what the problem is, but also trying to work out what outcome are they looking for. Because if they've come to you for medical advice, you're not the person to do that. You can't sort that. Likewise, there are certain things that you've got to manage their expectations on what we can achieve anyway, right? And I'll come on to those in a second. So those are the sorts of information that we can gather from the member. And then, right, this slide I know it's frightening because I know what it's like when I see slides like this go up. But there's a list of the different things that can help you. These are information sources. And I've put at the top there the Equality Act. This is an amazing piece of legislation. And if you haven't done Equality Act training, then do it. We've also got a discrimination course, which is based around the Equality Act. Those are really important things to do, particularly if, well, you have to do the discrimination if you're doing casework. But they're really important. And I'm not going to spend too much time going into those because those is a subject of other courses and seminars, and you can Google some of these as well yourself. The Health and Safety at Work Act is a catch-all phrase. It's a bit like the Equality Act in that respect because there are different elements within the Equality Act. But the Health and Safety at Work Act puts into place these next two, which are really important. The Workplace Health, Safety and Welfare Regulations, 1992, that deals with the facilities that should be in place in your workplace. And that's about having toilets, restrooms, staff rooms, things like that. We're lucky enough in Wales that school buildings still have to conform to the 1999 premises regulations as well, but that's ended in England. And I should mention here that these regulations cover England, Scotland, and Wales, but they're a separate, very, very similar regulations. They mirror each other. They're the same, but the Health and Safety Executive Northern Ireland deals with them in Northern Ireland. So that one deals with the facilities, and then the management of health and safety at work. Regulation 3 is a requirement for a risk assessment. So where somebody is identified as having a condition that's affecting their ability to work, there should be a risk assessment for it. And I'll do a bit more on that as we go on. The next two, this varies, right? These are all local agreements now. Your workplace sickness absence policy will be really important because of the effect. If that's the cause of the problem, the bullying because of your sickness absence, that's going to be the one you're going to have to refer to the most. And then the workplace health and safety policy should have something in there about these related topics, right? And a bit more depth coming into it when it comes later on. So I'm just looking down at my notes here just to see whether I've covered anything. I've done the Northern Ireland bit. Basically, the health and safety legislation shouldn't prevent disabled people from finding or staying in employment, so it can't be used as an excuse to discriminate against them. Employers have a duty to make reasonable adjustments. And basically, that's to say that the adjustments must be reasonable, as far as reasonable for them to make those adjustments. And reasonable just means what would the average person think? Was that a reasonable thing to do? To put it, well, nobody would question now if you had a member of staff or pupil in a wheelchair that you needed to put access in for toilet facilities, ramps, lifts, and all of that. That used to be considered unreasonable to go through those extra costs. Now it's absolutely standard. So reasonable is beginning to stretch a bit, right? So bear that in mind. There are, so the reasonable one might depend on, among other things, the size and nature of the business too. So doing this in a small business where there's 2 or 3 employees, an employer might get away with it. Most schools are part of chains or parts of local authorities. These are big organizations, so there's no excuse. I've put this bit in here because this is just copied from our website, by the way, right? So our website has got loads of good information anyway. But dealing with those protected characteristics underneath the Equalities Act, and I didn't want to go too much into it, as I said. Basically, I put there some of the things which you will need to look at if you were trying to sort out the policies in work. Don't really want to pick out too much there because I'm going to go into detail with these as we go on to the next one. But I put in there about risk assessment. So I'm going to just go on to what the detail around that is. Because this term gets bandied around as well without much explanation. Firstly, under that management of health and safety 1999, the risk assessments will have to be carried out by appropriately trained staff. That doesn't mean the assistant head or the deputy head who's just got the task of dealing with absence management or whatever. They should be appropriately trained. So that either means that they've had training in it or they've got a hell of a lot of experience in it. So, so they need that training to do the risk assessment. And the risk assessment will need to take account of sex and gender differences. And I've put under there a list of the different risk assessments that should be there in your health and safety policy in school or your workplace. The one thing I think COVID taught us all was that schools haven't got very good health and safety policies. And if it's something that I keep banging on about, is that we need more people trained to look for those errors, for those omissions in health and safety policies in schools, because that's where the work isn't being done. But I'll come on to that when we look at organising opportunities within dealing with this. Really conscious of the time, Claire. I am trying to rush. So you can see endometriosis in that list there. There's also a list of other things which can all be treated in a similar way. You know, and I put in there off our website, prostate cancer in men is one of the sort of top killers, and it's an important thing. Some of these things, the reasonable adjustments are the same. Okay. In particular, right, risk assessment should consider the needs, and we mentioned a few of the things, and Lara mentioned a couple of the symptoms of endometriosis and the things that medical advice is to lessen those symptoms. So it could be about having a colder classroom or a warmer classroom. It could be about having plenty of ventilation in the room, or a fan in the room. The ones I've mentioned already about access to toilet and shower facilities. Always a really difficult one in the school, because if you're on a secondary teacher, or well, primary, just as bad, has a timetable that hasn't got any breaks in it during that day, and then you've got a lunch duty or a break duty or whatever it is, we all know that we struggle to get through the day. At some point, you're going to have to nip out during your lesson. Now, if you're suffering from any of these conditions, that makes that far harder to do. So a simple mitigation might be just having somebody on call that you can go, can you come into my room for 10 minutes while I go and change a pad or something? You know, as simple as that. That's not rocket science. And then, of course, if you're suffering from extreme pain, having access to a safe, a quiet space, and lots of schools have got rid of their staff rooms now, but having the ability just to go sit down, a break from the classroom and relax will get you through the day so you can perform properly.
Mark, I said I wasn't going to butt in, but I think
No.
if you don't mind, can I at this point?
Go on, go on.
Especially around risk assessments. On our Managing Menopause in the Workplace section on the website, there's a lot of information there around what menopause is, etc., etc. But at the end, there are examples of risk assessments and things that you could be asking for reasonable adjustments. I know that that's around menopause, but there are many symptoms that are similar for endometriosis, adenomyosis, and menopause. So if you wanted to have a look at what some kind of suitable risk assessments and reasonable adjustments might be, just click on there and have a look at that as well. I don't know if you're going to mention it, Mark, so I'll stop talking now.
Absolutely, yeah. I've just got a quick note down here to point again at our website, and I know it gets a lot of stick, but but we've got some really good risk assessments on that, including the one for pregnancy at different trimesters and stuff. So some really good stuff on there. And the Health and Safety Executive website, Health and Safety Executive website has got a load of good stuff on there too, including as well example risk assessments. So there's no real excuse in some of this for people just to pull some of this stuff down and use it. I've mentioned there at that last paragraph about workplace stress, because on top of all of that medical conditions, there will be the mental side effects of it too, and the workplace stress. And we all know that workload is one of our top three issues with members. And this is always a really good one to look at. And I'll just name what they are properly, quickly, so that you see that this is what the Health and Safety Executive says employers should be looking at. The demands such as workload and work patterns and the work environment, so the demands of the job, how much control you have about the way you work and what you do, the support that you have amongst colleagues and from management, the relationships that you have with in dealing with some of those relationships within school, and whether you understand the role, your role in the big scheme of things in work. Not so important in this one really, but it's there. And the last one is change, and again, not so much important in here, but these are seen as stressors. Those 6 things are seen as stressors, which the Health and Safety Executives say that they should be risk assessed. So some of those are really relevant when it comes to dealing with endometriosis and other gynecological problems. So if I go on to my next one. So what are we going to do to deal with a case, the plan part of PIPO? This is really difficult, again, to say. It's a bit like Lara was saying at the beginning. The range of symptoms you get from endometriosis are so wide, a bit like the menopause, that it's difficult to say this is how you deal with it categorically. Step 1 is this, step 2 is this, step 3 is this, because it depends very much on what relationships you have. I'll say it, if this was a case I was dealing with in Merthyr, my own local authority, I have really good relationships with HR in particular. And if we had a sickness absence meeting discussing this, we'd both be agreeing that this is covered by the Equality Act, that it needs reasonable adjustments, and sickness absence related to this condition would not be counting towards the total of sickness absence. That I know that from a start, because I know that person I'd be dealing with. It might be very different where you are. And it depends on your employer as well, isn't it? Because if you between trusts and academy chains and local authorities, there's lots of different people to deal with. Wayne, who deals with one of our national negotiators, who deals with some of the chains, say their HR and health and safety people are far better than the people he's dealt with in local authorities. With some of the big chains, they know what they're doing and they do it right. Right, so it's not a blanket. Everybody out there is really crap at this. There are some people who really do get what their responsibilities are. I said about the policies earlier on, and I really want to, this is going to come into the organising bit as well, but what does the policy actually say about some of these conditions? I've only once come across a policy relevant to this discussion that we're having now. I shared it with Claire and I shared it with other colleagues at the National Executive. It didn't go far enough, but it was the first policy I've seen in 20 years. So, you know, I'm not going to kick them over that. That was a step forward, and we need to start working on it and changing and developing it. If you get nowhere with challenging the risk assessments and getting them put in place, if you get nowhere with having a reasonable discussion and trying to reinforce the Equalities Act and everything else, then you're only looking at two things, taking out the grievance or a legal challenge. All right, so I'm really conscious of that time, nearly there. Bear in mind what I said about that challenging a legal position for these next couple of minutes. Organising. If you are getting lots of issues raised in a school around poor management of sickness absences, that is generally symptomatic of a school where there are adverse managerial practices. That needs discussing with the members. Or is it a training issue? And we've got menopause trained people now, and I'm trying to think of what else that Sharon has just been trained on and is capable of going into schools and delivering training. Again, it's organising in the way that school staff, college staff, seeing the NASUWT logo, somebody coming in from the NASUWT, holding a meeting, explaining the issues to them, a bit like this thing, and organising and recruiting members as we're doing it. So, and then, of course, it's an idea that we can lead and develop the policy to improve those conditions for our members, right? So even leading on that is raising the profile of the NASUWT. I mentioned earlier about a legal challenge to this. If the case is discrimination, it has to go back to a paid official to be dealt with. And there might be paid officials on this course now who won't like me saying that, but that's basically it. As National Executive member, I can't take out a tribunal claim, only legal to do that. And you have to be careful about that because there's a time limit on which you can take out the tribunal. And it's 3 months minus 1 day of the last act of discrimination. There's flexibility around it, little bits of flexibility if the judge allows it, but you have to be careful that you stick to that and take advice, basically. Right? I've said it, I'm using my last bullet point now. I said at the beginning, there's no rule book on it. You have to, it's like following a road with hundreds of junctions and roundabouts on it. It'll take you off in different ways. So you have to be able to be flexible and go back to that point about what the member wants. what's a suitable outcome for them. And the one, because I've said about seeking advice from the office, I'm just going to say collective issues always carry more weight. If you collectivise around adverse managerial practices, sickness absence policies, you can get a successful ballot out of it. You can take action over it collectively. It will always hold stronger weight and more weight. And Claire, that's me finished. I think dot on one.
Not on two, Mark, unless we've gone back in time. But yes.
Oh, two, yeah.
Thank you very much for that. No, it was really useful, really, really interesting. As you've said around the discrimination element, if you are doing casework, please don't forget that you must have done the discrimination course. You cannot do the casework without the discrimination course for reasons that Mark has just mentioned around handing cases back. It is massively important, and keeping that training up to date as well. And Mark was mentioning some courses and training that we do. We do webinars, obviously this one, endometriosis, but we have menopause training as well, bladder health. We have flexible working as well. I know Lara, Mark mentioned earlier around part-time hours and flexible working, but we've got them on misogyny, sexual harassment, maternity, all sorts of things that we can come and give you information and give you training on that's going to help you dealing with any cases, dealing with any members who are suffering from endometriosis, adenomyosis, and any other illnesses which might need that bit of extra input. So I'm not seeing any questions in the Q&A box for you, Mark. I think you were really, what's the word? Words gone out of my head, brain fog.
Fast.
You covered everything. So thank you for that. Thanks both of you, Mark and Lara, for coming and giving up your time today. This has been recorded, so at some point it will be appearing on the website. Please do have a look at it and do check the website out, especially under the equalities section, because there's a lot of information which could be very useful for you as reps, as caseworkers. So Mark, Lara, thank you very much, and I'll see you very soon.
Yeah.